So as we close out this discussion, I mean we've covered a lot, I think, but Pankit, I have to have you start this. You recently said in an article, it was your last sentence, I could not be more jack-static about the future. What do you want to tell our audience what you exactly meant by that?
I don't know what I meant by that. No, just kidding. We have now 4 options, right, for the use of JAK inhibitors in the treatment of myelofibrosis, as opposed to one before. And I'm jack-static about the fact that we can optimize the patient outcomes with these different JAK inhibitors.
So each has a place.
Absolutely, each has a place. We didn't talk much about fedratinib, although you did mention this before. Fedratinib too is a good JAK inhibitor, especially in second-line setting, with some of the best outcomes over there. Pacritinib for patients with severe thrombocytopenia, where the other drugs don't really have a good set of data or just any set of data. Momelotinib, especially for patients with anemia. We have seen numerous studies, led first by the Mayo Clinic with simplified studies, momentum studies, that it improves anemia. And Rux, of course, is the king that's out there, one of the most potent JAK inhibitors that's there. None of these are going away. Each has a distinct place. But I'm jack-static about the fact that we can, one, optimize the selection of our JAK inhibitors for our individual patients. 2, perhaps by doing this, we can also down the line lead to and have different JAK inhibitor backbones in clinical trials. Maybe by doing that, we may lead to more optimal outcomes across the board. And beyond that, I'm also jack-static actually about non-JAK inhibitor drugs, right? So these are things, for example, POISA study that we mentioned about, with a very unique design that's going to isolate the patients who truly need additional benefit and see how much navtemadlin does. It should work. It's a disease-modifying drug in that regards. We talked about momelotinib as a backbone for momelotinib luspatercept, momelotinib nuvisertib. Imetelstat with impact MF is leading the field with OS as an endpoint. So for all these things, I'm very ecstatic and jack-static about the future.
Nasima, your thoughts about the future?
So I think Pankit covered most of the exciting agents, but I will once again emphasize the anemia agents. I think anemia has been an area in MF that has not been the forefront because spleen has been the major endpoint in the majority of the JAK inhibitor studies, and it was then noted that momelotinib had the additional anemia benefit. So I think we're in an exciting era because anemia has a negative prognostic impact, both quality of life as well as quantity of life. So if we're able to improve anemia, we would have come a long way in MF.
And we saw in Simplify 1 that if you were transfusion independent at 24 weeks, you lived longer.
Yes, so I think that's, of course, we want the patients to feel better, but you improve anemia and they would definitely feel better. There's a difference between hemoglobin of 8 and 11. And we see that in our patients all the time. And then I think the other thing, as we are borrowing from the MDS world, is early intervention for anemia. You know, if you're starting a patient on ruxolitinib and they're already borderline anemic at 9, you're only going to push them to the transfusion end. So I think combining anemia drugs with JAK inhibitors early on may also be the other path moving forward.
Before the anemia gets too bad. Ido, your thoughts?
Thankfully, with the help of everyone in this room, I think we have a better understanding of the biology of the disease. We have more treatments available. Obviously, transplant is still our curative therapy for myelofibrosis. And even though, we have good outcomes, there's room for improvement there as well. And so utilizing, some of these newer JAK inhibitors in the peri-transplant space, I'm interested to kind of get a better sense of the outcomes in that context. In addition, we have more donors available to us thanks to haploidentical transplantation, and we still kind of have to optimize that in the context of our conditioning regimens. And so I do think, at least on the back end, in addition to all the things that you've mentioned, we still have room for improvement in the transplant space, which will improve the outcomes for these patients as well.
No, absolutely. I love that you brought the transplant into our discussion today. That very important angle. I think it's not going away anytime soon, despite all the exciting drugs that we have. I don't have much new to add. I'll just say that I think all the synergistic combinations, the driver mutation-directed drugs, the anemia drugs, I think they're all important. They're all exciting. And regarding going back to JAK-static, I think the 4 drugs really each have a place. There are patients who need things beyond ruxolitinib, and so I think it's been very welcome to have them all. So again, thank you very much to our listeners, for your time, and I hope you enjoyed this and found it informative. Thank you.